Hello, my name is Angel Cantos. I'm going to talk about ABT-450, Ombitasvir and Dasabuvir with Ribavirin for hepatitis C with cirrhosis. Definition: cirrhosis is the presence of a large amount of scar tissues in the liver as a result of many years of liver inflammation and injury. There are many causes. Cirrhosis and chronic hepatitis C is a common cause of it. Studies have shown that 20% to 25% of people with hepatitis C will develop cirrhosis.
The hepatitis C virus is a major cause of chronic hepatitis, liver cirrhosis, and hepatocellular carcinoma. The virus is transmitted mainly through blood and reaches the liver via the bloodstream. The virus circulates as a so-called lipoviral particle associated with components of low density and very low density lipoproteins. The viral envelope glycoproteins are localized on the surface, whereas the nucleocapsid is located within the hydrophobic interior of the lipoviral particle. The nucleocapsid is formed of core proteins interacting with the viral RNA genome. Once the viral particle reaches the hepatocyte surface, it interacts first with glycosaminoglycans and syndecans, followed by binding to more specific receptors, including the scavenger receptor B1 and the tetraspanin protein CD81. The viral particle, complexed with these entry factors, reaches tight junctions and engages in further interactions with claudin 1 and occludin. The viral particle subsequently enters the cell via receptor and clathrin-mediated endocytosis. After its release into the cytosol, the clathrin-coated vesicle interacts with the motor protein dynein. Dynein transports the vesicle by walking along microtubules to reach the endoplasmic reticulum area. Acidification of the endosome lumen induces conformational changes of the viral envelope glycoproteins, which in turn interact with the endosomal membrane, leading to fusion of the viral and endosomal membranes. Membrane fusion is followed by uncoating of the nucleocapsid and the release of the viral RNA genome into the cytosol. Binding and assembly of ribosome subunits on the viral RNA is the starting point of HCV polyprotein translation. A signal sequence located in the beginning of the translated polyprotein allows the ribosome to be targeted to the translocon on the endoplasmic reticulum membrane. Translation can thereby proceed further, giving rise to a polyprotein which is cleaved by cellular signal peptidases and by the viral proteases into 10 mature proteins. The structural proteins which make up the viral particle comprise core and the envelope glycoproteins E1 and E2. P7 and NS2 support viral particle production while not being incorporated into the particle. The replicase components NS34A, NS4B, NS5A, and NS5B are sufficient to support viral RNA replication. A HCV replicase proteins, in concert with host factors, induce rearrangements of the ER membrane, including the formation of double membrane vesicles. These vesicles cluster to form the membranous web, which represents the site of HCV RNA replication. Viral RNA synthesis is catalyzed by the RNA-dependent RNA polymerase activity of NS5B, which acts in concert with other viral non-structural proteins, as well as several host factors. After synthesis of a negative strand RNA intermediate, multiple positive strand progeny RNAs are generated from this template and either used for translation and replication or packaged into nucleocapsid particles. The latter process is thought to be initiated on the surface of lipid droplets that are targeted by the core protein. It is assumed that a network of NS5A delivers the viral RNA to core proteins for assembly into nucleocapsids. Nucleocapsids form at ER-derived membranes where E1 and E2 accumulate in conjunction with P7, NS2, and host factors including apolipoprotein E. The viral envelope glycoproteins are acquired by budding, a process which appears to be linked to the very low-density lipoprotein machinery. Newly synthesized virus particles are thought to be transported to the cell surface in export vesicles via the cellular secretory pathway. Finally, they are released from the cell by exocytosis to reach the bloodstream.
Application in medicine. The interferon-free regimen of ABT-450, a protease invader, ritonavir, Ombitasvir, Dasabuvir, and Ribavirin has shown efficacy in patients with hepatitis C virus genotype 1b infections, the most prevalent subgenotype worldwide.
I am Pietro Andreone from the University of Bologna, Italy, and I'm here to present about a study evaluating the efficacy of treatment with antivirals in subjects with chronic hepatitis C. The study is named PEARL 2 and included 3 direct antiviral drugs with or without ribavirin. The 3 drugs are 450 ABT, that is a protease inhibitor, Ombitasvir, that is NS5A inhibitor, and Dasabuvir, that is NS5B non-nucleoside polymerase inhibitor. This study was performed in 186 subjects with chronic hepatitis C receiving a 12 months treatment. The key inclusion criteria were age between 18 and 70 years, the absence of cirrhosis, and a previous non-response to pegylated interferon and ribavirin. The key exclusion criteria were co-infection with HIV or HDV, and genotype different from 1B. The efficacy endpoint were sustained virological response 12 months after stopping treatment. Non-inferiority and superiority sustained virological response compared to an historical control group of subjects treated with Ribavirin, pegylated interferon, and Ribavirin. The safety endpoints were evaluation of hemoglobin decrease, adverse events, and laboratory abnormalities. The safety endpoint patients included in the study, while the intention to treat analysis of efficacy was performed in increase of bilirubin. In conclusion, dear colleagues, three direct antiviral agents regimen without ribavirin is an optimal treatment efficacy in subjects with genotype 1B, no cirrhosis, and previous non-response to pegylated interferon and ribavirin. Thank you for your attention.
Pros and cons. Adverse events were assigned to each study visit. The site investigator classified events as mild, moderate, or severe. Data on all adverse events were collected from the start of study drug administration until 30 days after the last dose. Data on serious adverse events were collected throughout the entire study period. Adverse events and serious adverse events occurring during the double-blind period plus 30 days after the last dose of active study drugs at report.
Our next speaker is Mark Sulkowski, who is going to present on behalf of a group from the United States the Turquoise 1 data on the safety and efficacy of the 3D regimen.
Design considerations for the part 2 of the Turquoise 1 study. The first part of the question is a larger question which deals with drug-drug interactions between the hepatitis C regimen and the HIV regimen, which in my mind is really the foremost question when approaching the treatment of this patient population. There was a formal healthy volunteer interaction study done with Dasabuvir and all 3 drugs in the 3DAA regimen. Now, one thing I neglected to mention was that when the patients went on to the 3D plus ribavirin, the ritonavir in the 3D regimen was used to boost the Dasabuvir. In other words, they did not take an additional ritonavir 100 milligram dose, so that was discontinued during the 12 weeks. The interaction study suggested no significant effects on the Dasabuvir levels, so this was felt to be a safe regimen to combine. It's interesting to note that we did see hyperbilirubinemia in those patients. My own view is that was not likely due to the raising the Dasabuvir levels, but rather due to ribavirin-induced hemolysis, as has been seen in other studies such as Photon 1. With respect to darunavir, there have been formal healthy volunteer drug-drug interaction studies conducted, and these do permit the going forward with studying this. Now, the studies did show a reduction in the C trough of darunavir of roughly 40%. So the studies will go forward to assess both QD and BID dosing of darunavir in combination with a 3-day regimen. So those are certainly important things to look at going forward.
Christina?
Thanks. I have one question, Mark. Did you measure adherence in the two patients that failed?
Well, thank you for asking. Another important point I neglected to mention, the two patients were adherent to their hepatitis C drug therapy by pill count, and really they had achieved a undetectable viral load to suspect hepatitis C. We also did not see any alterations in their HIV suppression. So I don't think we can attribute those two virologic failures to non-adherence. I would point out that as we've seen in the other studies, such as Turquoise 2 of cirrhotics, this combination of null PEG ribavirin response plus cirrhosis plus 1A appears to be a difficult patient group to treat. Overall, there were 6 patients with those characteristics, 4 of whom have achieved virologic response in the 2 failures.
Microphone 2, I'm sorry, I can't see who it is. Could you state your name?
Swan.
Oh, hi, Tracy.
Of the 5 people that blipped with regard to HIV viral load during treatment, what were they on Atazanavir, Raltegravir, or some of each?
They were on, actually, it was almost an even split. It was 3 and 2 of Atazanavir and Raltegravir. So no obvious pattern with respect to these blips of HIV-1 RNA during therapy.
Microphone 3, Dr. Bagnani.
Hi, Mark. Thank you very much. So, Mark, I was going to ask, looking at the fantastic results that we've seen in part 1 of the study, do you think part 2 of the study should exclude the 24-week arm?
Another great question. And certainly, when one looks at the data from the entire phase 3 development program of the 3 direct-acting antivirals plus ribavirin, the only group that seemed to need the longer course of therapy, that is 24 weeks, were PEG ribavirin null responders with cirrhosis and genotype 1A. So I think it is appropriate to adopt that same 12 weeks for everyone else, but for the patients with this constellation of difficult to treat characteristics, perhaps 24 weeks would be beneficial. So those are in discussion for part 2.
Okay, thank you very much, Mark.
Thank you.
Issues applied in Ecuador. The rate of sustained virologic response is the study were high even among patients with an AO response to prior treatment, who made up nearly half the study population. Such patients have been the least likely to have a response to the treatment. Regimens comprising PEG interferon, Ribavirin plus a protease inhibitor.
The hepatitis C virus is a major cause of crisis of a negative strand RNA intermediate. Multiple positive strand progeny RNAs are generated from this template and either used for translation and replication or packaged into nucleocapsid particles. The latter process is thought to be initiated on the surface of lipid droplets that are targeted by the core protein. It is assumed that a network of NS5A delivers the viral RNA to core proteins for assembly into nucleocapsids. Nucleocapsids form at ER-derived membranes where E1 and E2 accumulate in conjunction with P7, NS2, and host factors including apolipoprotein E. The viral envelope glycoproteins are acquired by budding, a process which appears to be linked to the very low-density lipoprotein machinery. Newly synthesized virus particles are thought to be transported to the cell surface in export vesicles via the cellular secretory pathway. Finally, they are released from the cell by exocytosis to reach the bloodstream.
Conclusions. In conclusion, previously untreated patient with HCV genotype 1A or 1B infection and no cirrhosis who received ABT-450, Ombitasvir and Dasabuvir with or without Ribavirin had high sustained virologic response rated that were superior to the historical response rated with perchlorantraniliprole, Ribavirin plus telaprevir. Although Ribavirin did not improve the response in patients with genotype 1B infections, our findings suggest that Ribavirin confers an additional benefit for patients with genotype 1A infection.
Our next speaker is Mark Sulkowski, who is going to present on states, the Turquoise 1.
So I'll start with the second half of the question, which was about the 1B patients, do they require ribavirin? My own opinion after analyzing these data as well as those of the monoinfected patients are that this group of patients I would anticipate do not need ribavirin if they're infected with 1B, and that is one of the design considerations for the part 2 of the Turquoise 1 study. The first part of the question is a larger question which deals with drug-drug interactions between the hepatitis C regimen and the HIV regimen, which in my mind is really the foremost question when approaching the treatment of this patient population. There was a formal healthy volunteer interaction study done with atazanavir and all 3 drugs in the 3-DAA regimen.
Thank you.